Okay, so welcome everybody to the last installment of the 4th annual Montreal Oscillometry Summer Seminar. I'm not going to spend a lot of time with the introductions. Just to remind you that the series is being recorded, and you can Google the Respiratory Effectiveness Group Technologies Working Group to get to the website where we'll be hosted until we can build our own. I'm happy to say that we will be building our own website because thanks to all of our corporate sponsors, we have enough money to go forward with that project, and likely enough money to publish the talks should the presenters wish to have them transcribed. We'll take care of everything and get back to you in the future with the logistics of that. And so the program is very exciting today, I think. We're going to be learning about what lungs look like when they're transplanted and the donors are smokers. So Chung-Wei Chow and Natalie Belasova from University of Toronto will be giving that talk in a couple of minutes, with Peter Calvary giving his insights and direct and comments. Stuart, who is my co-host here up in Montreal at McGill, will be talking about a large cohort of neuromuscular patients that he and Arash Rad have been studying over the past year, with Julian Allen from University of Pennsylvania giving the discussion there. I'm going to share with you COPD from both the community practice point of view and the CAN-COLD cohort. And Jason has kindly consented to talk from south of the border and give us his view of things. Julian will then come back to give us a talk on a phenomenon that he and others have observed, which we're trying to figure out what it means, and I'll leave it to him to explain what reactance inversion is. And Zoltan Antosh from University of Budapest and Zagreb will be, or from Semmelweis will be commenting on that. And finally, we're going to end the series very appropriately with Frederick Trinkmans from Heidelberg and his experience using oscillation mechanics to assess COVID-19 affected patients. And Sam Bayat from Grenoble will be leading the discussion and the comments on that. So hopefully with only 5 talks, we have enough time to cover all of the ground. I think we'll keep an eye on the time, and I'll try and give you a 1 to 2 minute warning as you approach the 10-minute mark. And then I'll try and cut you off as you come to 15, because I definitely want to leave time for discussion. So with that, I'm going to turn the floor over to Chung-Wei. So Chung-Wei, are you there with us? I'm going to stop sharing my screen. And I hear crickets for Chung-Wei. So Stuart, could I get you to maybe slide into Chung-Wei's spot, and we'll hear from Chung-Wei after you finish?
Okay, I'll give it a try. Let me get my slideshow up, and I have to share screen, which I'm trying to do, but isn't working. Share screen, share. Okay, let me get my PowerPoint up. And okay.
Perfect.
Can you see that?
Remind everybody, please keep your microphones muted during the talk. We've had everything from dogs to dishes to garbage trucks, and I'd like to keep this last one on the quieter side. So thanks. So Stuart, I don't have a presentation mode here, but I can see your slides well. This is the presenter mode, so I see your slide plus the next slide coming.
Okay, don't know how to change that.
Well, then you know what? We can accept it as it is, because I can read it very well from my point of view, so I'm assuming everybody else has the same view.
Okay. All righty, so let me start. So I'd like to start out for thanking Ron for asking us to present here, and also put in a plug for Ron himself for all the efforts that have gone into these multiple sessions for the summer and now fall oscillometry seminar. So what we'll be talking about today is oscillometry to assess respiratory function in rare neuromuscular disease with respiratory muscle weakness. And this is really work done by Arish Rad here in Montreal, and unfortunately he wasn't able to be with us this morning, so I'll be presenting. In terms of background and rationale, you've all heard a fair amount to date in terms of the relative potential benefits of oscillometry and where it fits in the assessment of respiratory function in patients with lung disease. And we'll hear a lot more about that this morning, and so I won't belabor that. This really, in a sense, was an extension or a continuation of work we had done in cystic fibrosis patients, trying to look at those with rare or unusual respiratory diseases. In looking at the literature, we were quite surprised that there was really very little data in this particular patient cohort, which motivated us to continue to do the study. And the data actually rests with this one publication, which is now almost 30 years old, coming from the Netherlands. And this, to give you some background here, was a study of just under 30 subjects, which is a reasonable number, with a mean age of approaching 30. But if you look at that, there was quite a wide range of age, including those who were actually children, and a good portion, 40% of the patients, were actually classified as children being less than 18 years old. The diagnosis, as you might expect, were a good portion were spinal muscular atrophy, also Duchenne muscular dystrophy, and a few with post-polio syndrome, as well as miscellaneous disorders. I think it's important to note that in this study, they made significant efforts to exclude patients with asthma, as defined by negative history, no prior bronchodilator use, and in fact, the negative bronchodilator response in the pulmonary function laboratory. As you can see that the patients or the subjects here had lung function consistent with significant respiratory muscle weakness. Since this dated to the early 90s, the study was done with a non-commercial device and settings and parameters which are a little different than what would be recommended today. So there was a fairly broad range of frequencies that were tested. The sessions were relatively brief. And I guess this is consistent, as we'll see, with some of the parameters reported, emphasizing a pediatric perspective. As well, the coherence value accepted was was quite high, and perhaps excluded subjects who had some underlying respiratory dysfunction. The values here for R8 and R28 and X8 obviously would perhaps correspond to what we would see for R5, R20, and X5 in adults. And this is in kilopascals and centimeters of water for those in North America. It's just multiplying by 10. And as a rough approximation, these values don't look terribly abnormal, which was the consensus statement, if you will, of these authors. So with this in mind, we felt comfortable to go ahead and do a study in adult subjects with rare neuromuscular disease and associated respiratory muscle weakness. And this was done at the Montreal Chest Institute here at McGill in Montreal. The diagnoses were somewhat similar to what we had seen previously in terms of patients with spinal muscular atrophy, Duchenne's, as well as other muscular dystrophies. In addition, we had a substantial cohort or subgroup of patients with post-polio syndrome, as well as a significant number who had myotonic dystrophy. And so spirometry and oscillometry were performed according to published guidelines with the usual parameters that we report today. And for oscillometry, the tremoflow device from Thoracis was being used. In terms of subject characteristics, mean age was approaching 50, a little older than what we had seen in the previous Dutch study, and these were all adults. There was a little bit of male predominance. In terms of physical characteristics, we were reasonable. Patients were perhaps, or subjects were perhaps a little bit on the short side and slightly obese in terms of BMI, or excuse me, overweight. This is really the heart of our results, and again, this is going to be relatively brief. So we have spirometry and oscillometry here. And looking at the footnote, it's important to note that as entry criteria, if you will, spirometry was abnormal in all subjects. Oscillometry was a bit different and was abnormal in only some of the subjects, approximately 60% of the group, and was normal in the remainder. And just as a quick overview, the abnormalities were consistent with their underlying complications of their underlying neuromuscular disease and or other comorbidities, just a few of which are outlined here. You can see that in terms of spirometry, there were some modest differences between the two groups. However, as noted, there were really distinct differences in the oscillometry with the standard parameters listed here expressed in absolute units. For those who might like to look at Z or Z scores, that's now shown here in red, and you can see that there was really a distinct separation between these two groups here. This is a correlation. This slide shows the graph, table I should say, shows correlations between spirometry and oscillometry. In this particular example, they're expressed as Z or Z scores, and the R values are shown. You can see that the value correlation or the R values suggest relatively weak, or in some cases really non-existent correlations or association between spirometry parameters and oscillometry parameters. And this is really in quite distinction to what is reported in the literature, and as we'll see a little later today, in asthma and COPD, that is obstructive disorders. And this was really true whether results were expressed as absolute values, percent predicted, or as here, Z-scores. And the results were also not really dramatically different when they were analyzed separately for the group A subjects with abnormal oscillometry or the group B subjects with normal oscillometry. So again, wrapping up rather quickly here, that in terms of conclusions, clearly spirometry is abnormal in adults with rare neuromuscular disorders with associated respiratory muscle weakness. However, oscillometry can identify those with normal versus abnormal respiratory impedance, and the latter is generally due to the consequences of the underlying neuromuscular disease and or other comorbidities. And I'm sure we'll discuss a little bit more about this with Julian. And the utility of oscillometry in the management of neuromuscular disease with respiratory muscle weakness, particularly with disease progression in those of rare as well as more common disorders, warrants further evaluation. Just briefly, I'd like to thank the subjects who participated in this study, as well as the staff for the Montreal Chest Institute, outpatient clinic for their patients and assistants. Just like to note, I didn't do this at the beginning, but myself and the other authors involved in this study have no conflict of interest of any kind. Okay, and I'll be happy to entertain any questions. Thanks again very much for this opportunity.
Well, Stuart, thank you very much, and I congratulate you. You got 1 minute to spare on the 10-minute mark, so well done in the timing. This is most unusual for this seminar. Jules, are you out there? And
I am.
Can you take the floor, please, and share your thoughts and maybe lead a discussion?
Absolutely. So that was just fascinating. You know, I think, Stuart, as you pointed out, the last time I think this was studied was that article by Wessling, which was in the 1990s, I believe.
Correct.
And you're to be congratulated for having such a large cohort and a very understudied group. I want to dive a little more into your results, which are interesting. You know, when you were comparing your abnormal oscillometry group to the normal oscillometry group, the main differences mechanically were that the reactance was higher in the abnormal oscillometry group, and the resistance was also higher in the abnormal oscillometry group, which is interesting. And then there was a big difference in the area, in the low frequency reactance area. So as I was thinking about why that would be, it seems like it points to some stiffness of the respiratory system at lower frequencies. And the question is, why would patients with neuromuscular disease have increased stiffness? And Stuart, I'll let you comment on that. You know, there are articles in adults that this is consistent, I think, with what's been shown. Studies of chest wall compliance, for example, in patients with neuromuscular disease that were done by Detroyer and Asten, where they showed that patients with neuromuscular disease have stiff chest walls. And in work that we did in infants with neuromuscular disease, we found actually that the opposite. We found that infants with neuromuscular disease have actually more highly compliant chest walls even than normal infants. Normal infants obviously have high chest wall compliances compared to adults. And we found that infants with neuromuscular disease had even more highly compliant. So it implies that there's a progression from a compliant chest wall to a non-compliant chest wall. And I think it's very important because I think that has to do a lot with the pathophysiology of why patients with neuromuscular disease go into respiratory failure. So let me stop here and let Stuart just respond to that a little bit, and then I've got some other thoughts as well.
Yeah, no, thank you for the comments. I think the work of, you know, Neil Pride and Andre Detroyer and Mark Asten, you know, have pointed out that there's clearly changes in the chest wall and probably changes in the lung as well. And that's supported obviously by CT studies showing areas of atelectasis, which may not be all that apparent either clinically or on conventional imaging. So, you know, also our population here was quite a bit older, particularly the post-polio patients are probably as a group the eldest. And, you know, associated comorbidities, I think, really contributed to as well. In addition, you know, scoliosis, for example, progresses with age. Comments made by Detroyer and Stan in terms of fibrosis and ankylosis of chest wall structures are obviously potentially participatory. Initially, when we started this study, we were thinking of looking at patients longitudinally and trying to look at the success or failure of lung volume recruitment maneuvers, perhaps, and following that with this sort of procedure. And unfortunately, that hadn't panned out and now is obviously very problematic in the COVID era. In terms of the resistance changes, we found this interesting. I mean, some of our patients had previously been intubated, some had tracheostomies and so on, and some of this was quite remote, and presumably that accounts for some of the issues, but we did have patients who also had well-established or sometimes less well-established diagnosis of asthma, and in particular one or two with significant COPD and substantial smoking history. So I think that can contribute as well. But even in terms of looking at the resistance, that the, if you will, R5 was less abnormal quantitatively as opposed to the R520, and speaks to perhaps, you know, some small airways disease in these patients, whether it be related to the breathing pattern, low lung volumes, previous respiratory tract infection, pneumonia, and so on. You know, it's a little bit open to conjecture, and we're trying to delve into that a little bit more by digging into their histories, which obviously isn't always that straightforward, dealing with people of age 50 who have records not only in our institution, but elsewhere as well. So time will tell, but thank you for your comments.
Yeah, just a couple of other things. So I think we're thinking along the same lines here. I do think that the chest wall develops some contractures as these patients age because they're always breathing at very low tidal volume. So your thought about volume expansion maneuvers, I think, is right on. It'd be really interesting to look at these results, you know, before and after volume expansion maneuvers. I don't know. So the other thing I'll say is that we did not do this, and I don't think you did it as well. Is to separate out the various forms of neuromuscular disease, because you might expect that there might be some differences between upper motor neuron diseases and lower motor neuron diseases in terms of stiffness and tone of the chest wall. So it'd be really interesting to look at people who fall into those categories. And the last thing I'll say is that the resistance issue, I think, is also really interesting. And I do have one other thought about that. You know, in patients with I don't know how many of your patients had severe kyphoscoliosis. But in patients with severe scoliosis, sometimes they can get rotation of their spine to the extent where it actually compresses the central airways. There's some nice CT studies of that. And so that may also play a role in a high resistance in these patients if there's central airway compression from, not from the vertebral bodies posteriorly.
Yeah, no, that's very interesting. I mean, we've seen that in isolated cases as well. I haven't looked for it in detail in this population. Again, as these people age, they don't necessarily have lots of imaging or CTs and so on. And again, even if they do, it may not be accessible to us because it's at outside institutions. But it's interesting a point. In terms of subgroups, I mean, we were trying to build up significant numbers so we can start doing some of those comparisons, if you will. Unfortunately, COVID has, thrown a monkey wrench into that. So we do have a large myotonic dystrophy population, and we're going to try and look at them in a little bit more detail and see how they compare to the others. But hopefully, if COVID ever disappears and I'm still around to do it, perhaps we'll look into this in more detail in the subgroup. Thanks very much.
Great, thank you.
Okay, well, thank you, Julian, for leading that discussion. We still have 5 minutes to spare, which again is most unusual in this seminar series. And I see Aisling McGowan has a question. And since we have time, Aisling, why don't you unmute yourself, turn on your video, introduce yourself, and then ask your question yourself. Aisling, if you're having difficulty, I can read your question out for you.
Can you hear me now? I'm having a few technical problems. Can you?
Yep, very well.
Great, hi. In Dublin, in Beaumont Hospital, Professor Richard Costello, quite a few years ago now, they conducted a study on mortality rate in motor neuron disease patients, and they followed them using SNP or a SNF test. And I'm just interested, have you ever looked at that versus oscillometry?
I haven't personally. The SNP maneuvers have been looked at in some detail by Marta Kaminsky and Basil Petrov, colleagues here who have an interest in neuromuscular disease. This study, if you will, is a little bit of a convenience sample. So we were catching patients during an outpatient visit, and we really didn't have simultaneous data in terms of extensive pulmonary function testing, specifically muscle pressures and sniff pressures and so on. That's obviously something we'd like to do in the future, and we're planning on going back and trying to fill in that data. But again, a lot of that is on hold for the current time, unfortunately.
I think it would be very interesting thing to look into.
Agreed.
Because it was very powerful results in terms of, when the SNP dropped to a certain threshold, I think it was 30% predicted, then the mortality rate was very short thereafter. Yeah. So it would be a much simpler test to perform oscillometry as well, because SNP and SNF can be extremely variable.
Yeah, the sort of party line for a lot of this in general is that I think some of this testing we're pointing to is really complementary. And I think the oscillometry will help us in those cases where it's a little bit confusing as to, is it the respiratory muscle weakness alone, or are there other significant pulmonary and particularly parenchymal factors that may be contributing?
Yeah, I agree. I think it's excellent to have other options as well. And it's very nice for phenotyping as well.
Excellent. Thank you.
Thank you.
My related comment is, in my experience at my community hospital, I've applied oscillation mechanics to tracheostomized patients, not necessarily neuromuscular, but trying to figure out whether there was a component of asthma, and was able to take one fellow and treat him for asthma, which was undiagnosable because he couldn't do lung function testing. I think in the neuromuscular arena, where we may have many of these patients on tracheotomies, again, the potential for being able to have an objective test of lung function is very attractive. I see Peter Calverley has got a question to everybody, and I will make this the last question before we move on. Peter, do you want to unmute? And
yes, I hope you can hear me.
Turn on your video. Yeah,
I just feel
turn on your video too, please.
Oh, okay. You want the pictures as well.
We want the beautiful view. Hey, there you
Make
go.
sure it's you.
Right. Right. Let me just. Okay. Right. Yes, I am here. So, quick question for Stuart. Upper airways in these people are very variable. You've got, like all of us who've studied these types of diseases, it's a very variable state of affairs, particularly with the Duchenne dystrophies often having perhaps a less compliant upper airway than, say, sorry, the Duchenne dystrophies have a more compliant upper airway compared with the myotonic dystrophies. So I wonder whether diagnosis influenced this and how you got on with the practicalities of making the measurement in people who often have problems with maintaining a tight seal around the lips.
Yeah, as mentioned, we don't have you know, particularly subgroup analysis or comparisons, and an excellent point in terms of you know, getting a good seal and so on. And by and large, we were able to accomplish that. It took a bit of effort. Because of the oscillometry unit, we really were not able to use any modified interfaces, and we just sort of tried to do our best with individual subjects. You know, we did have trials that we weren't able to include because there were leaks, but we tried to adhere to standard guidelines to minimize that as much as possible. And, you know, we haven't gone back and looked at it in extensive detail in terms of trying to recognize leaks that we may have missed that may have influenced data, and that's sort of something we look forward to doing with some intra-breath analysis. But
that would be really interesting, Stuart.
Yeah. But you know, I think that may, you know, potentially that may have been a factor, but hopefully not a significant factor.
Yeah.
Okay, great. Well, thank you everybody for your questions, Stuart for your presentation, and Julian for leading the discussion. I'd like to turn the floor over now to Chung-Wei Chow and Natalie Belasova from the University of Toronto. And Peter, I guess you can stay on the platform as well, because you'll be leading the discussion after the presentation is over. So Chung-Wei, take over the screen if you can. Like Stuart, you'll not stop sharing, and
Yeah, I'm gonna...
let's see how this goes.
Terrific. Thanks very much, Ron, and thank you, I think, on behalf of all of us for organizing these seminars. And in some ways, kind of sad that this is the last of the series for this year, but hopefully next year we'll meet in person. So last year, I had presented some of the early work that our group had done looking at lung transplant patients and monitoring with oscillometry post-transplant. And this year, Natalie Belasova, who is a new research fellow in my group, will be presenting some of her work looking at oscillometry in donors who have a significant smoking history. So Natalie, I'll let you take over.
So good morning, evening, and afternoon, everybody. So I'm Dr. Natalie Belasova, obviously very new to this group. Hopefully everyone can see my screen.
Yes.
So today, I'm going to present my work on oscillometry in lung transplant recipients, and particularly examining smoking history in the donor and how that influences oscillometry results in our lung transplant patients. So just a bit of background on why we even use smoking donors. I mean, the latest guidelines that we have for donor selection do describe an ideal donor as somebody who's less than 55 years old, has a less than 20 pack year smoking history, and a number of other parameters. But the reality is that very few of our donors actually look like that. We do know that when we're using lungs from smoking donors, these recipients have a lower overall survival and a lower overall highest achieved FEV1. They just never quite get to the same lung function as the non-smoking donors. However, we also know that the overall risk of death is higher if these patients remain on the waiting list rather than use those smoking donor lungs. So the potential risk of using these marginal donors always has to be weighed up against the risk of dying on the waiting list. And just to run through what we know about oscillometry in smokers and COPD. So we know that R5 to R20 and X5 can differentiate smokers from non-smokers, even without a diagnosis of COPD. We know that R5 to R20 correlates with gold stage and with COPD assessment score. And this is just one of the graphs from that Italian paper demonstrating the association with the gold stage. And we know that a number of oscillometry parameters do correlate with small airway dysfunction seen on various modalities, including MRI and endobronchial coherence tomography. And again, that holds true for both COPD patients and for heavy smokers without a diagnosis of COPD. So the aims of my project were to compare oscillometry between patients receiving lungs from smoking and non-smoking donors, and also compare oscillometry to conventional PFTs for detecting lung function abnormalities in these patients. So, so everyone who consented to the study would have their oscillometry tested on the same day as they're coming in for their routine post-transplant PFTs and their clinic visit. So we're using the tremor flow device, and we took the time point of 8 weeks post-transplant and compared the smoking versus non-smoking donors, and we defined heavy smokers as anyone with a 20 or more pack year smoking history. So we had 268 patients enrolled, and we excluded a small number, so there were 6 patients for whom there was no donor smoking history recorded, and there were 9 patients who didn't have any testing done. So these were patients who either died short, so they were enrolled in the study but died early post-transplant, or had a very long hospital stay, and so hadn't actually had any testing. So we had 253 that we included, 106 with non-smoking donors and 147 with smoking donors. And out of those, 36 were in that heavy smoking group. So the baseline characteristics were similar between the non-smokers and the smokers for most of the parameters, including recipient and donor age, CMV mismatch, the underlying disease, and the BMI. There were a couple of differences. So there were more males in the smoking group, and also there was more EVLP use in the smoking group. And for those unfamiliar with sort of lung transplantation, so EVLP is ex vivo lung perfusion, and it's a means by which our surgeons can try and optimize a set of lungs that, for whatever reason, is thought might be suboptimal or may not be performing as expected. So it allows them to essentially try and optimize those lungs before transplanting or before deciding whether to use them. And there did seem to be more EVLP used in the smoking group. Now, interestingly, if you look at the subgroup of heavy smokers, those differences between in male sex and the EVLP use actually disappear. But we do see a difference in the time to extubation after the initial surgery. So there is a significantly longer extubation time in the heavy smoking group. So when we compare the non-smokers to the non-smokers, so to patients whose donor had any smoking history, we actually find that everything looks, that there are no significant differences in either spirometry or oscillometry values. But when we take the subgroup of heavy smokers, the results look quite different. So suddenly now we have significant differences in R5 to R19, X5, the expiratory component of X5, AX and FRES. We also see a significant difference in the absolute value of FEV1, but when we look at the percent predicted FEV1, the difference is non-significant, and also in the FEV1 over FVC, the difference is non-significant. And this is again showing the key results for the oscillometry, so the R5 to 19, X5, and AX, all at 8 weeks. And again, you can see that the results are grossly similar between the non-smokers and the smokers, but the difference emerges when you take the heavy smoking subgroup. So in conclusion, patients who received lungs from donors with a history of heavy smoking had small airway obstruction and increased lung stiffness detectable on oscillometry at 8 weeks. But this difference was not seen in patients with a moderate smoking history. And further study is needed to really look and see whether these changes persist over time and whether they lead to long-term graft dysfunction. So thank you, everyone, and thank you, Dr. Chow, for giving me this opportunity.
So, Peter, over to you, unless Chung Wei, do you have anything to add to the talk before Peter comments?
Perhaps, why don't we start with the comments now, and then I have some intergraph sort of work in progress that I can show after that.
Okay, that's great. So we have in fact probably 12 minutes for a good discussion here.
Right, well, I'll have to try and limit my question to 11 minutes in that case, Ron. You know what I'm like. That was really very interesting, and congratulations on all the work you've done. I really enjoyed your paper in the Blue Journal as well. I think it was excellent, and I think that this shows what is achievable. And you presented the data very clearly, and it's reassuring in some ways that people with a lighter smoking history do not seem to carry any immediate consequences in terms of ill effects. I wonder whether the background disease had any influence in terms of whether somebody fell, if you were, the numbers may be too small at the moment, but if you were a heavy smoker and you ended up with somebody with an ILD chest wall, as compared with the COPD chest wall, whether that might make any difference. I suspect that may be, the numbers may be too small to distinguish, particularly given the small number of people, but there were 11 individuals who were heavy smokers in the ILD group, and if you count the CF as well, there was something like 17 people who might have a larger chest. So is there any other extrapulmonary factor which you think might be relevant in explaining some of your findings?
I mean, given that the groups do appear to be similar, there's nothing that's striking based on the data we have at the moment. And as you say, the numbers, particularly when you split them up into the primary disease, are very small. So, you know, there's only 11 ILDs and 5 CFs. So, yeah, Chung Wai, do you have any thoughts on that?
I think that the one possibility may be that oftentimes the ILD patients tend to be the older patients where perhaps there's an unconscious bias in terms of whether, when it's time that you use a marginal donor lung, whom do you give that to? And oftentimes the ILD patients are the ones who tend to be the ones who are on the rapidly deteriorating list, where the risk of dying on the wait list is much higher. That's one possibility. But that said, all of these patients that we have enrolled in this study are all double lung transplants, and the IPFs and the ILDs tend to be the patients where we would put them on the list where a single is possible.
That's a very good point and well made, and I think it's relevant. And the other issue, of course, is that the donor age of these people may be heavy smokers, but and they obviously were heavy smokers to get to more than 20 years with an average age of 45. But perhaps the full impact of the damage had not yet appeared. I guess my one other thought is that in your Blue Journal paper, you did suggest that early changes in AX were predictive of subclinical graft malfunction. And I wondered how the changes in reactions that you were seeing in this data set in the heavy smokers compared with those sorts of data. I mean, were they of the same order of magnitude? Would you expect them to be people who might be running into problems?
Chung-Wei, I'm not sure I know enough about your original data to to answer that.
We did look at in that paper and in subsequent sort of an ongoing analysis between the folks who developed acute rejection versus those who didn't. Smoking did not come out as a significant sort of factor. However, that said, what we did not do was to look at it in the context of the heavy smokers versus those who were the non-heavy smokers. And so this may be part of and we didn't have enough numbers in that original data set to really do that, but I think that, that's a very good point, that moving forward, that should be factored in. But the magnitude of change in terms of the AX values is actually pretty similar, because those who had acute rejection certainly had the higher AX values compared to those who didn't.
So basically, I think this is a really very nice piece of work and very nicely presented, and I'll be interested to see how it develops.
Yeah. And I think actually Jeff had a question, if I saw that.
You did indeed. Jeff, can you unmute yourself and show us your face by turning on your video? And we'll
Sure, Ron. Thank you. Yeah, no, just a question about the percent predicted FEV1s not actually being significant, like the significance just disappearing. It's a p-value of 0.06 relative to the FEV1 actually in this table that's on the screen. And the relationship between the actual lungs that are being used to measure those FEV1s. The lungs are those of the donor, not the recipient, but I believe you calculate the percent predicted based on the demographics of the recipient. And so it may be the lung size, because a larger lung will give a larger FEV1. And so there must be a reason why there's possibly larger lungs in the non-smokers than the heavy smokers, but I don't know.
So, I mean, our surgeons do, I mean, there is size matching when lungs are selected. So yes, you do make an excellent point that that these are donor lungs, but we're comparing them to kind of recipient, recipient age and BMI and height. But yeah, lungs are typically size matched. We do find that with our recipients so it's actually the underlying disease of the recipient plays a part in this, in that our recipients with COPD tend to get larger lungs for obvious reasons, and recipients with ILD will often get sort of undersized lungs for their height, and just because their chest cavity is smaller. Yeah, but there is size matching that happens. But yeah, the ILD lungs tend to be undersized.
Yeah. It's potentially just an added source of variability that leads to poorer performance of the predicted value, just enough, but I don't know.
Clement Wren, I think you had a question, and then we'll follow it up with a question from Charlie Irvin, if you both want to unmute yourselves and turn on your videos.
Yes, hi. I'm Clement Wren from Riley Hospital for Children and Indiana University in Indianapolis, Indiana. I haven't had a chance to attend this seminar before, but it sounds really interesting. Been involved in oscillometry for many years, ever since I listened to a talk by Jules Allen on oscillator mechanics in the 90s. So this is a very interesting study, and especially kind of differentiating between heavy and non-smokers. I was just wondering if so you didn't see any difference in the smoking group overall, but I was just wondering whether you or others have looked at other methods to look at small airways flow, such as density dependence of flows, and also whether or not there's any data on MBW, which isn't directly measuring small airways flow, but certainly can be affected by small airways disease.
I mean, my answer is not that I'm aware of. Chungwa, do you know if that has been examined in these patients?
The only group that I know, the only paper that I know of is a slightly older paper that had looked at the multi-breath washout in patients who have had CLAD, and showing that particularly for the patients who had BOS, that you could see a difference. But other than that, I am not aware of any groups that have looked at this in this patient population. I know, and we, given the, these patients come in, at least prior to COVID, on a weekly basis to have their pulmonary function studies done. And so we've never looked at this, and I know that very, very early on in the program, probably in the early 80s, there were some studies where they looked at helium flow volume loops in this patient population, but I'm not sure that that data had really, I know that data hadn't been published, and I'm not exactly sure, where that data sort of sits. But I think one of the sort of attractive things that we find with the oscillometry is that it just adds so little time. And it's so easy for the patients to do when they come in through the PFT lab, that we're able to sort of collect this volume of data in a short period of time.
Thanks. Yes, I think it would have been really hard to do density dependence of flows on like 200 patients coming through your clinic.
Okay, great. Charlie, over to you.
I had two questions, actually. So the first is lung volume. I mean, we sort of were dancing around that with the lung sizing, but do you have any thoughts about how you're going to control the data for the fact that you've got different size chest walls, different size lungs that are being transplanted? Do you have independent measures of lung volume by any chance?
So we do, but we don't have them at that particular time point. So patients typically will have a TLC, so full body plethysmography at the 3-month mark, and then later on at 6 months, 12 months, and so forth. We don't have that data for this sort of early time period.
Okay, but you could.
Yes.
The other data sets. And
yeah, so we're certainly in the longitudinal kind of, I guess, follow-up. We certainly can get that data. That would be very interesting.
And then if you go to the box and whisker plot, I was really struck with the variability in the groups. Not so much the difference between the various groups, but the extreme variation, which I realize can be driven by some outliers. But what if you look at the different tertiles of function? Do the ones that are, I mean, we'll just pick on one, let's pay AX, the ones that are at the -4 and below, are they somehow different than the rest of the group?
So I'm just trying to manage my screen so that I can actually see what I'm looking at. So the X5. So you mean these outliers?
Yeah, that is a group.
Yeah. So we haven't looked at. I guess we haven't really examined the outliers closely. I mean, yes, certainly this is a very, very heterogeneous group of patients. I mean, because we're looking at,
because you've got a cohort size now that's big enough that you could maybe, what characterizes folks that have oscillatory indices that are clearly at one end or the other, both good and bad?
yeah. So I certainly have not done that in my with my data. I know that Chunwai and the rest of the group have been looking at some intra-breath data, but I'm not sure if they're looking particularly at the ones with the sort of really extreme results.
Because in the end of the day, we're dealing with individual patients, not groups. And so if you do get a patient where the resultant lung mechanics are clearly outside of the normal, outside of the mean anyway, what do you do with that?
Yes, it's. I mean, that's.
I mean, it's clearly not. It can't be explained away by smoking in the donor lung. It's could easily be something else because you're seeing it in the non-smokers too.
Yes, I mean we are seeing these extreme sort of outliers in all the groups. So yes, there's definitely likely to be other factors involved. I mean, overall, lung transplant recipients are an extremely heterogeneous group, and
no, I appreciate the difficulties.
Okay, I think we'll take one last question from Ramon Perez. I think you wanted to put a question to the Toronto group. So turn on your video and your microphone, please.
Yeah, well, my question is that I see that the values of resistance are quite low. On average, half a centimeter of water per liter per second in the non-smokers, and always the average is less than 1 centimeter of water per liter per second. It seems quite low. And even in some patients, if you look at the range, there are negative values of resistance. So this surprised me a little bit. That's all. That it's just an observation.
Thank you.
Ramon, I think that's R5 minus 19. It's the difference, not the resistance.
Oh, sorry. Then forget my comment. Forget my comment. I misunderstood. Sorry.
You are forgiven, especially after your excellent presentation with your ventilator last seminar.
Sorry.
Okay. So if there are no other comments, I guess I'll take over sharing the screen and we'll slide into my talk.
If you don't mind, Ron.
Yes.
If I could just quickly show 1 or 2 slides. I think this sort of will address a little bit, perhaps some of the earlier questions about the heterogeneity between the amongst the smoker donors.
Please.
And so let me just see if I can share my screen. And let me just because of time, and this I will say is a work in progress. So we don't have that full data set that Natalie has analyzed. And are you seeing my screen right now?
Mm-hmm. Yep.
So what this is this is an analysis of only the donor, the smoker donors who have greater than 25-year history of smoking. And each one of these sort of paired points is actually an individual patient. And what you can see here is looking at the values, and these are interbreath measurements, looking at the AXV and the AXV dot. And what you can see here is that there is, in fact, a great deal of heterogeneity amongst these patients. with some of these clearly falling into the COPD, expiratory flow limitation range, and those who are essentially normal.
And when I interrupt you, please could you explain to the audience what AXV and AXV dot are?
Yeah. So I think this probably is a better sort of description of what AXV and what AXV dot are. On top here in the top row are here is the spectral oscillometry of a patient who's received this lung, and then the second one is and both of these patients receive lungs from a heavy smoker. And what you can see here is that this, on the spectral oscillometry, this particular oscillogram is completely normal. This is also very abnormal with a high resistance and a high R5 to 19, low AX and high AX and low X5, whereas this is normal. These are the intra-breath measurements from the same patient, actually taken on the same day. And what you see here is that this actually looks essentially normal. So here, if we were to look at the beginning of inspiration, end of inspiration, and the expiratory loop, this is the resistance values, which really doesn't change very much. In contrast, this patient, you can see that the beginning of inspiration here, end of inspiration here, and the expiratory loop here. And so this is the AXV. This is the reactance curve. And here you see the beginning of inspiration, where there's very little change. And then here we see evidence of expiratory flow limitation. So these high AXV values and the AXV dot values are very characteristic of the flow limitation seen here. And this is the corresponding curve or the loop in of the impedance over flow. And again, you see that this is the this is the AXV dot curve. And so what we clearly see is that, with amongst the donors with a heavy smoking history, that there is quite significant differences between the graft function. And I think the challenge for us is to really find a way to be able to actually identify these grafts and to be able to discriminate the grafts of good lungs versus bad lungs before they're actually transplanted. So thank you, Charlie, for that question.
That's great. So people can read more about this in the Lorax paper. I think it was ERJ 2017, which Zoli was the senior author on, that describes these integrated areas of reactance as a function of volume and reactance as a function of flow. I think that this holds a lot of promise, and I'm looking forward to seeing other studies that incorporate this metric. Well, in true oscillometry seminar form, we have now taken 30 minutes each for the first two talks, but I think we indulged the Toronto group because I think it's very exciting what you guys are doing. I'll take over the screen now, and I will bring down the hammer and limit the next three talks to 20 minutes each so we can finish on time. And I guess, Stuart, I'll ask you to take over the clock minding duties and give me a heads up when I've reached the 10-minute mark, because as you all know, I get over enthused with my presentations and can absolutely run away with them. Okay, now that having been said, I need to find my share screen here, so give me a moment. Okay, share screen, this one. Can you see my screen?
Of course.
Okay, good. Slideshow. Good. So now we need to get the correct slide deck up. Give me a moment. And that looks like it. And slideshow. And can you see full screen slides?
No.
Can people see my full screen slides?
Yes.
Perfect, thank you. Okay, so the title of the talk is Oscillometry in Community Practice and Can Cold, a tale of two cohorts. And I apologize to the fans of Dickens for my paraphrasing his novel. My disclosures are few. I'm an unfunded researcher, so a lot of much of my expenses are fortunately offset by my generous benefactors who are acknowledged here. But nonetheless, I persevere and I have fun with this hobby. I'm going to be using two principles to guide the talk. One of empiricism, which is really the root of much of our science and medicine. And I think it's well summed up in 4 words, first put forward by one of my heroes, Sir William: observe, record, tabulate, and communicate. And I try and take this to heart as I go through my daily practice. And the other is, I think, just a general principle in life is that we're forced to deal with many, many complex things which are hard to understand. And so Kenny and Keeping in their statistics book quote Fisher's, a quantity of data which by its mere bulk may be incapable of entering the mind is replaced by relatively few qualities which shall adequately represent the whole. Among these relatively few quantities are those which are known as moments. And so as we go forward in talking about oscillometry, the complexity would be nicely, I think, summarized and disseminated if we could simplify it somewhat. So to this audience, there's no need to convince you that oscillometry has a potential for a robust, sensitive, easy deployable characterization of lung function. And we all come across the frustration when we talk to our colleagues about its complexity, which limits understanding, and also the obscurity of how oscillation mechanics relates to the other usually monitored and gathered metrics within daily practice, be they imaging or traditional physiology or even patient-reported outcomes. So the overall objective is a very broad one, narrowing down to a specific. I'd like to facilitate clinical uptake of oscillometry. I would possibly like to simplify oscillometry to a single metric for everyday clinical use. And finally, I'm attempting to relate oscillometry to patient-reported outcomes and traditional lung function parameters. To effect this, I'm going to use my own practice, which will be a retrospective convenience sample, and I'll call that the derivation cohort. And everything that could go wrong with such is there, including cherry picking, because I'm the chief cook and bottle washer. I do all the lung mechanics myself. I order all the ancillary testing. I see and evaluate the patients and hence classify them to their groups clinically. But on the other hand, the Montreal site for the Can Cold study, I will use as a validation cohort. I don't know these patients at all. I have nothing to do with gathering the data. And so I think that will serve as a good check on what I do. We will look at the biometrics, the patient-reported outcomes, oscillation mechanics, pulmonary function testing, and both groups were studied with our local IRB approval. The Can Cold cohort is a typical cohort, well done with same-day metrics of oscillation mechanics, full lung function, patient-reported outcomes, whereas my West Island cohort, it's really more the real world, same year. Things are within months of each other in terms of these same parameters. And finally, I'm going to classify the subjects into 6 groups. Healthy, gold 0, and by that I'll mean signs of hyperinflation or scooping of the flow volume loop, and then the usual stage 1 to 4 baseline spirometry. Both cohorts were studied with the tremoflow oscillometer, and I'll normalize both data groups using the CORA predicted values. Lung function testing was used one of 2 body plethysmographs. All lung function testing, my cohort or the Can Cold, were performed by an RT, a respiratory therapist. But the difference, as I said previously, in my group, I personally did the oscillation mechanic measurements in all of the patients, whereas the respiratory therapist performed them in the Can Cold group. Statistics would be the usual methods. We're going to look at the distributions and whether they're normal, abnormal, and decide how to process them. I'll express the data as median and IRQs, Mann-Whitney U-test with post hoc DUNS, and Spearman's or Rose or Pearson's R's, depending on distributions, and always with the corrections for multiple values. Just a sidebar, coding is something that I've long avoided. I think, Jason, if you're out there, it was 89 when you introduced Anodata to Meekins. That was the first time I'd used a computer. And unfortunately, I avoided learning coding at that time, but back in November, I decided to take up Python because I was so impressed with the graphics, and I find them an efficient way of expressing data like this. So that's, I've encouraged any of you to look at this Python program because I think it's extremely powerful. Stuart, I'll rely on you to tell me the time because I'm looking at my watch, which has stopped. So that's the second glitch this morning after my computer crashed. Anyway.
Yeah, 4 minutes.
Okay, thanks. So we're not going through this table. It's just to show you that in my own practice, I have a full spectrum of COPD, including golds 3 and 4, looking at the biometrics, patient-reported outcomes, and spirometry. The CANCOL group is somewhat different. You'll notice 4 and 3 are absent. Gold 2 plus is basically gold 2 with one individual in gold 3. So it's really COPD-like, and the majority of the group is based in the healthy control and gold zeros. And this is just to show you that I have the oscillation metrics in my own practice done up by the same classification, and here's the CANCOL. But I think an easier way or a more effective way is to look at some of the distributions in selected metrics. So here's the R5 in the upper left-hand corner for my cohort, organized by the groupings. And you can see a progressive increase, but still a large overlap between groups. And the lower panel on the left is the percent predicted values. And we have the CANCOL cohort similarly displayed on the right. I'll give you a minute just to look at that. You can clearly see that the CANCOL cohort, even though if we ignore the last 2 boxes in my group and focus on the first 4 back and forth, they're a less sick group, even though they belong to the same COPD stage, at least by oscillation mechanics. And we see similar findings when we look at the low frequency reactance, again, absolute upper and percent predicted lower between the 2 cohorts. And yes, to address Charlie's issue of outliers, I've checked these outliers and they actually make sense, and I can sort of give names to these individuals and give you anecdotes. For example, the gold 0 outlier on percent predicted on the lower left-hand panel there, above 5,000, that was a gentleman who had terrible bullae in the upper lobe, was being considered for actually volume reduction surgery, but unfortunately succumbed to complications of a COPD before I could get him to a surgeon. But his clinical behavior was more like a gold 3 or 4, but he was so hyperinflated that he had pseudo-normalized his ratio, rendering him into a gold 0. We're not going through all of this. This is just to show you the heat maps. My practice on the left, the CANCOL on the right, with all of the parameters that I've listed, regressed against each other in a cross-correlation table. We're only going to focus on this tail here, which is the oscillation mechanics, and relate them to the spirometry parameters there. And just a quick word about distributions. The uppers show you what they look like non-transformed absolute AX versus FEV1, for example, versus the transformation of the AX. And that just dictates which of the 2 regressions I'm going to use, either a Spearman or a Pearson, but the results are quite similar. So if we look at the oscillation mechanics and the cross-correlation table against themselves, we see if you had to pick, and if I gave you the time to look through everything, you would conclude that probably the AX overall related to its parameters might be the best representative of the group. I just put it forward. It's confirmed, however, interestingly, in the CANCOL group, which was completely independent from me. If we look at
Ron, you're at 9 minutes now, 1 minute to go.
Thanks. Here is the oscillation mechanics related to the spirometric values. And again, if you let your eye fall through the table, you'll come across the row of AX as probably overall being best related to each of the spirometric parameters. And likewise, the FEV1 seems to relate well to or best out of the group of spirometric. So it seems that the absolute AX and FEV1 may be sort of at a crossroads. And we essentially see the same thing in the CANCOL cohort. Now we have lots of parameters in both groups. This is the complexity. Yet, despite the physiologists telling us about the value of all these things, the epidemiologists have embraced the FEV1, put it to clinical trials over the decades, starting with the Framingham study, and really shown it to be a good predictor of mortality, not only COPD, but cardiovascular disease. Should the epidemiologists do the same thing with one of the oscillation parameters, namely the AX? I put it out there as possible. So to summarize, of the popular oscillometry parameters, the AX relates most strongly to the other oscillometry parameters in a community practice cohort. Could it possibly be the moment of oscillation mechanics? The AX relates most strongly to spirometry metrics and lung volumes and diffusing capacity and airways resistance, but I didn't show you that data for the sake of time. And both findings are in fact reproduced in the CANCOL cohort. So I'd like to take away that our results support the notion that for practical purposes, oscillometry, at least in the context of COPD, may possibly be simplified to a single parameter to render it more acceptable to real-world clinical practice. I think more interestingly, this empiric observation merits detailed exploration on a theoretical and modeling basis as to better understand why this might be so. And I'll just end by quickly acknowledging my patients who volunteered happily and enthusiastically their data. Phi Lai and Palmina Massiano, who worked with Jean Barbeau, and they gathered the CANCOL data, and Jean, of course, for sharing it with me. Industry partners, who I acknowledged previously, and of course you all for listening and your comments to come. So thank you, and that's the end of this. And with that, I'll turn the floor over to Jason, who I hope is online, and will lead the discussion.
Yep, I'm here, Ron. Can you hear me okay?
I can hear you very well.
Great, well, excellent talk. And, you know, I have to say, you may be unique in the world in terms of a practice clinician who collects data of this nature and collates it so effectively. And I don't think we can underestimate the value of what you've done here in terms of gaining experience with oscillometry in actual real-world applications. To move on to your the main theme of your talk, or the main conclusion, which is that AX seems to be the person to go after. I think this makes a lot of sense on theoretical grounds, and your comment about Fisher's moments is quite apropos also, because moments, of which the first moment is the mean, the second moment is the variance, and so forth, the third moment is the skewness. These are all integrated quantities. You calculate them by integrating over all your data. And so it's significant that AX is the only integrated quantity that you have in your list of oscillometry parameters there, because it's in fact the area under a curve, so it's an integration. It actually would correspond to the 0th moment of your data rather than the first. But the fact that you're integrating over the data, essentially averaging it if you like, is always a good sign from the point of view of handling data, because it tends to average out the noise. It tends to be more robust in the presence of noise than a single value that you pull out of a whole sequence. So, you know, R5, one resistance measurement, R20 is one resistance measurement, so forth, same for X5. So the idea that AX would be more robust makes a lot of sense. From a theoretical point of view, it's also interesting because, you know, you gave me an opportunity to talk about this a couple of sessions ago. If you want to sort of understand what they mean, my very strong personal opinion is that you have to start invoking models of what you think you're dealing with, because then you get a sense of the link between structure and function. But if you look at what AX actually means in terms of the single compartment resistance elastance inertance model, for example, it also, you can argue, has great sensitivity to things to changes in lung stiffness, because not only does an increase in elastance, all other things being the same, pull down the reactance curve, make it more negative, the area is going to get bigger simply because the curve is moving further away from the frequency. It also pushes the resonant frequency out to higher values. And so the limits of your integration increase. So it's kind of like a double whammy in terms of anything that changes the stiffness of your system, which raises an interesting point, which is why would the the stiffness of the system be such a relevant and sensitive marker of lung disease in general. And this I think, gets to the interesting question of airway narrowing versus lung de-recruitment. I think if you had to put it bluntly in its most simple terms, it's like that. And, you know, with asthma particularly, we tend to think of this as an airways disease, airways narrow, the resistance goes up, so people's minds tend to get naturally drawn to resistance. But in fact, in my experience in animals, and also now in recent years looking at patients, often the biggest signal is in the stiffness of the lung, which suggests that when, for example, you challenge a patient with methacholine, or you just look at them at baseline, they have a smaller lung. They have de-recruited lung. Either that's atelectasis or just airway closure, trapping gas, whatever it is. This seems to be a very ubiquitous and significant part of the phenotype. So for all those reasons, both theoretically and in terms of what happens physiologically, it makes perfect sense to me that of all the parameters you've listed there from spirometry, AX would be the one to go after. So I'll leave it there and see what you think or anyone else thinks about that.
Well, thank you, because, you know, it's been fun to go back and revisit the physiology I left over 30 years ago at the end of my fellowship. But the way I've always thought about it is in terms of, I guess, not necessarily if the airways were closed or whether it was atelectasis, but just the time constant inequalities that you get in a heterogeneous lung, which are apparent at regular respiratory rates. But I mean, when Macklem and Woolcock did their frequency dependent compliance, what we saw back in that paper in the 60s was there was a clear stiffening of the lung, at least dynamically, as they went up to panting frequencies, which showed, you know, was a nice demonstration of these time constant inequalities. And these were done in people who were just simply smokers without spirometric obstruction. And so when oscillometry came along clinically available, I thought it would be fun to exploit that. And indeed, the way I think of it,
Ron, speak closer to the microphone, can you?
Yeah, and the way I think of it is that there's indeed, as the frequencies go higher, that effectively you're seeing less lung volume. And so that same forcing volume is going into a diminishing area of lung, which gives you a stiffer signal. Anyway, that's how I naively think of it as a
in fact, Zoltan Hantosh just made exactly the same comment in the chat. And if I'd been more complete, I should have said the same thing, that heterogeneity, so inhomogeneous airway narrowing, can give rise to this dynamic stiffness as well. So it's a sort of something that's affected by pretty much everything that goes on in the lung. Oh, by the way, you're now coding. So
I'm going to stop my screen. I can see comments because I can't manage the chat as things go on. If people just want to raise their hands or speak up, if people have other comments,
Peter, let's say something.
Yeah, just a quick thing. I mean, I think what oscillometry's told us is exactly the things that Jason Zoltan have just highlighted, but it is also a clinical point that your patients in your community practice are much sicker than those people identified randomly in the community. And their oscillometry looks different, as you pointed out in your slides, in very general ways. And that does tell us that oscillometry is telling us something of clinical value as well as of interesting theoretical significance. I think I would just be a little cautious, and if we're going to sort of bet the house on AX, which is the best probably of the available things, we still need to quite think through whether this is the ideal measurement in all settings. And obviously I have a bias towards partitioning things, but some of that began to come out from the last slides that Chung Wai showed in the transplant setting, that saying, yes, that's the only number you need to know, and only in that setting, may still be an oversimplification. So it's good to reduce the number of variables, but we've got to make sure that we've got the right variable for the right setting.
I couldn't agree more, which is why I made the point of in the context of COPD, because having no experience with the other disease categories apart from asthma, it may not be the case. And I think, in fact, Stuart, when he looked at CF, it was more the X5 and not the AX. So it may be that it will be disease specific what we decide to hang our hat on.
Well, actually, you know, you can do some sort of integrated parameter and resistance well if you want. You can argue that that's a useful thing to do. In fact, our group is trying to do this at the moment. I must say, under the watchful eye of Zoltan, who has identified himself as one of the reviewers, very usefully for us because he's given us some great comments to chew on. But one thing we propose, just in case it might be useful, is if you calculate the area under the resistance curve above the baseline defined by R20. So in other words, if you have a completely constant resistance, it would, if R5 minus R20 was 0, this quantity would be 0, but you calculate the area under the entire resistance curve above the R20 baseline. You get a sort of an equivalent, which is presumably related to some heterogeneity index. So you can do these other things, but you know, anytime you can integrate your data and use all of it rather than just pulling one number out, that's generally a good thing.
Okay, that's great. Well, I'm going to bring the hammer down and put on my chair hat and take off my presenter hat because it's 8:21, so I'm in overtime, and I really would like to not take away from the other discussants and the other presenters, and I won't shut the meeting down at 9 o'clock, so we can run a few minutes overtime for people who don't have to run. So with that, the next presenter, I would like Julian Allen from the University of Pennsylvania take over, and the discussion for Julian's talk will be Zoli. So take it away, fellas.
Give me just a second. You can hear me, I take it, right?
Yes. Are you able to go full screen? If not, we'll make do with this. Perfect.
Reactance inversion at low frequencies really long, function is relevant.
And I remind everybody, mute your microphones because I hear some whispering going on.
Okay. Can everybody see here and
Yes.
okay, great. So I want to talk about a phenomenon that we've observed at CHOP and Indianapolis with Clement Wren, who's on the line as well. These are the authors of this abstract. Joe McDonough is my bioengineer. He's here as well. And I want to acknowledge Jason and Zoli for very enlightening discussions that I've had with them about this phenomenon. But I want to completely say that any flaws in this presentation are completely my own. So I'll start with a case presentation of a child I actually saw about a month ago, a 6-year-old male who presented with acute onset of retractions and hypoxemia. He was not beta agonist responsive, but was steroid responsive. He was referred to me from Virginia. He had traveled to Disney in late February and early March. So of course that's that travel and that Disney are both two major possible exposures at that time. But his COVID PCR and antibodies have been negative. His CT scan is shown here. He had diffuse interstitial lung disease, and his other evaluation for infections and rheumatologic disorders are negative, so we are planning a lung biopsy. But I wanted to point out something on his the curve. So he had oscillometry done in Virginia, and this accompanied him in his records. And if you'll notice just the reactance here, can you guys all see my pointer?
Yes, we can see it.
Okay, great. You'll notice that reactance curve has a very distinctive appearance that doesn't look like any reactance curves we've seen today, or indeed any reactance curves we've seen in the last 4 weeks of the seminar, or we saw last year. So, so this is an unusual finding that I want to discuss. So just to talk about the normal generation of the reactance curve, as you know, at high frequencies, respiratory system reactance is dominated by inertial properties that when you're oscillating very quickly, you have to constantly accelerate and decelerate. Excuse me one second. And at low frequencies is more dominated by elastic properties because the lungs have more, the airways have more time to fill. The various units have more time to fill and develop a back pressure. And this is analogous, there's analogies to electrical properties. So an inductor is analogous to mechanical inductance, and a capacitor is analogous to mechanical compliance. And a capacitor has more time to fill. Capacitor has more time to charge at low frequencies, and so therefore that back voltage becomes higher. And the same thing with units with certain time constants in the lung. At low frequencies, there's more time for those units to fill, and so the impedance related to elastic properties goes up at lower frequencies. Now, this is not what the curves that we've been seeing today look like, and that's because there's a convention that we consider the inertive properties to be positive in sign and the elastic properties to be negative in sign. And so this graph here translates to something that looks like this, and this looks more like what we've been seeing today. The resonant frequency is that frequency at which the inertive and the elastic properties are equal. And so they actually cancel each other out, which is the reason for this, this convention of having a negative sign. And so when they are equal to each other, then the reactance is actually 0 at the resonant frequency. And so this graph then shows it in this way. So basically you're just inverting this curve here. And here's the way I think about this intuitively. It has to do with phase relationships. So pressure and flow oscillations are in phase with each other. Inertial pressures are in advance of flow swings, and elastic pressures follow the flow swings, the peaks. And the way I think about this intuitively is that in a inertial system, if you're trying to accelerate a mass, that's here on the lower left. Sorry, my arrow is gone. But if you accelerate them, here it is. If you accelerate a mass, you have to give pressure before you're going to get flow. And so the pressure swings are going to precede the flow swings. Whereas to get pressure back from an elastic component, like a balloon, you have to put flow into it before you get pressure back. So that explains why these are 90 degrees out of phase, either before or after flow. And so the pressure swings and inertial and elastic properties end up being 180 degrees out of phase with each other, which is why when they're equal at the resonant frequency, they cancel each other out. So, so that gives rise to this curve, and the curve that I showed you before looks like this, which it shouldn't look like, and so does the curve of the boy that I showed you at the very first slide. So I'm going to, it takes a certain amount of guts to present a finding like this, because we've seen this time and again. It shouldn't happen, and this is a quote which I attribute to myself, which is never has possible to look more like a fool in front of more people simultaneously than since the introduction of the World Wide Web and Zoom. So that's where I am with this, but it's my story and I'm sticking to it. So let's talk about what this might be. Why is there this inversion?
Please mute yourself. I think it's Nadia Stanowitz from Albany. I've called you out, Nadia.
And by the way, so the system we're using, this is a study, this is a boy we did with cystic fibrosis. We're using the VIAR system, which is the descendant of the Jaeger system, which is impulse oscillometry. And you can see that actually VIAR and Jaeger came up with a program which converted a graph that looked like this to a graph that looks more acceptable. And I'm not exactly sure what the math that they use is to do that, but we'll get to that in a minute. So we've started a study of former preterm children who are now at school age, and we've observed this phenomenon of this positive inflection of reactants, which we've termed reactants inversion. Our study population now is 4 to 6 year old former preterm infants who had received mechanical ventilation as neonates. And actually, we're looking at a group who got steroids in order to get them off the ventilator, and a group who didn't get steroids to get them off the ventilator, and now comparing this group. It's still blinded. We don't know what the differences are yet. As I said, we're using the Jaeger master screen system. And we also have been looking at reactants and separating it into inspiratory and expiratory components. So this is the summary of our data. We divided our children into 2 groups, and this is thanks to Joe McDonough, who originally made this observation of the difference between the inspiratory and expiratory reactants as being greater in children who show this phenomenon. So we divided them into 2 groups, one with reactants inversion, and that's these blue lines here, and then one who did not demonstrate reactants inversion, which are these gray lines. And the average number of the dotted lines and then the difference between the inspiratory and the expiratory reactances are shown on either side of the dotted lines. So this lower curve here is the this lower curve is the expiratory. I have a very sensitive screen, touch screen. The lower curve is the expiratory reactants, and the higher curve is the inspiratory.
Hey, Jules, you're at 10 minutes.
Okay. So what we found was that at every frequency above 5 hertz, elastic reactance was greater in the reactance inversion group than in the non-reactance inversion group. And at all frequencies below resonance, the difference between expiratory and inspiratory reactance was greater in those with reactance inversion. So the standard oscillometric testing model predicts that if frequency is less than frequency, the absolute magnitude of reactance should increase hyperbolically as elastance dominates. The reactance inversion, I've been told it may be due to leaks, but we've not seen leaks in these patients. We're very careful about leaks, and the baseline has been steady. So the fact that it occurs more in children with greater reactance and with a greater difference between inspiratory and expiratory reactance makes us think that perhaps excessive expiratory airway narrowing is leading to more lung units participating in oscillatory flow during inspiration than expiration. And we think it's likely to be a low frequency phenomenon. So for example, in people who have tracheobronchomalacia with airway collapse, at lower frequencies, this airway collapse may be more evident. And since inertance is related to 1 over area, cross-sectional area of the area, or actually area squared, we've been wondering whether this inertance, increased inertance at low frequencies might deflect the curve upwards. So this is my last slide. This is what I would say could be a hypothetical mechanism for that, whereas you almost have two systems that you're oscillating, one at low frequencies and one at high, where at low frequencies you have high inertances, and then there's sort of a flip to at higher frequencies, which could explain a curve that looks like this. And this is my last slide. It may be also testing instrument dependent, and it may be seen only in impulse oscillometry versus forced oscillation. I think Zoli has some thoughts about this. So either it's testing instrument dependent, or it may be related to a low frequency phenomenon of airway collapse. And the simplest way to test for that would be to compare subjects with IOS and forced oscillation in the same sitting rather. So I think that's the end. Sorry, I went a little bit over.
No problem. That was great. Thank you very much, Jules. So Zoli, if you want to make yourself appear and unmute yourself, you can take over the discussion at this point.
Yes. Can you hear me?
Yes, I can hear you.
Okay.
And I can
Thank you very much. Actually, this is probably the most provocative presentation I've ever seen. if you see if you can go back to the previous slide where the potential, another, just one more back. Yes. So my instinct thought was that this is how a leaky respiratory system should look like. So in the inverse reverse, I would say reversal in reactance, and not inversion because it's not mirrored. Just instead of going to the minus infinity, reactors suddenly change the directions and points to 0, which means that it's not an elastic system any longer, but a leaky, elastic, inertive, resistive system. So if you put an RLC model, either physically or mathematically, in parallel with a resistor, and you fiddle with the resistor value, you will see that resistance would flatten toward 0 frequency instead of keeping on increasing, and reactance reverses and points to 0, because in a leaky system at 0 frequency, reactance should be 0. So that was my instinction, but you quite categorically rule out the equipment leak or leak around the mouthpiece or improper nose clipping. So then what else? I think that the sudden increase in inertance towards lower frequencies is probably very unlikely. So I can't, because the inertive reactance is proportional to frequency. So you can multiply the inertance by 100 or 1000 to keep the reactance curve out of the usual shape. So what else? I would probably exclude all physiological explanations underlying these data. I do remember, or probably I have to state that I have never seen such a reactance reversal in any other studies. Probably in pediatrics, other systems where you encounter 10 or 15 centimeter water per liter per second and resistance, preterm children, maybe former BPDs. I have seen thousands of data with other setups, and I've never encountered such a shape in reactors. So then, I'm only left with the assumption that probably it is specific to the setup you experience these strange curves. We have tested this setup with 5 other setups with RAR a few years ago, and we exposed these systems to very high elastance and very high resistance mechanical models which did breathe. So this was a breathing model, and to my best knowledge, we never encountered that on the iOS setup which we had. But my long-term memory is improving relatively to the short-term memory, not absolute terms, but so I remember many, many years ago studying reports, posters, where impedance data obtained by the iOS system were plotted below 5 Hertz, although the fundamental frequency of the train of impulses the iOS uses is 5 Hertz. So you are not allowed to neither interpolate, but definitely not extrapolate from this frequency region. So I did see a presentation, which I don't want to name, where impedance data were sort of extrapolated down to 1 Hertz. And that shape was exactly the same what you represented, the reactance inversion or reactance reversal. So I think that it must be a software bug. So in the iOS system, the oscillatory event is a short impulse, which is extracted from the recording, given a new baseline, and then zeros are added to reach the 200 milliseconds period time. The first justifiable frequency to estimate impedance, and it multiples 10, 15, etc., up to 35. But if you add more zeros by mistake, you can artificially expand the period time to 300 milliseconds, 500 milliseconds, 1000 millisecond periodicity, which is false and artifactual. And then with 1000 millisecond, that is 1 second time window, you will have an estimate for the 1 Hertz frequency, which is totally wrong. Mm-hmm. I did see such things with 3 Hertz plotted from 5 Hertz fundamental oscillations. So I think there must be a software bug which neglects one or more criteria and makes estimates out of the region of reliability. That's my impression. Yeah. I don't know.
Let me just say one other thing there, and that is that, so, you know, my conclusion is that maybe when using the iOS system, we ought to concentrate on the results at 10 Hertz or higher rather than these lower frequencies, which then, of course, calls into doubt any quantity that that takes into a lower frequency into account, like the R20, R5 minus R20 would be suspect as well. So, you know, I think it's a really important thing for us to all talk about and try and understand what the signaling processing is.
Can I ask a question?
Yeah, of course.
Yeah, I think Zoltan gave a great overview of what I think is likely the problem. Julian, you know, you and I had an extensive chat about this last year. And my immediate reaction was the same as Zoltan's, which was that it was a leak. And his talk about the technical problems may be spot on. Just sitting here, though, I'm wondering something else, and I'll just mention it quickly because I don't know if it's crazy or not. But if you have a floppy trachea, so tracheobronchomalacia, and the resonant frequency, the frequency at which that trachea wants to flop, is around about the point where you're having this flow reversal, could it be that when you put the oscillations in, instead of seeing when the volume goes in, the pressure increases, when it comes pressure decreases, which is what it would interpret as a stiffness. Instead, it sees no such change because all it's doing is being accommodated by the flopping backwards and forwards of the airway wall. So in other words, the airway wall resonance is kind of interfering with things. But I have to think about this more. It just occurred to me, and I don't know if it's possible, but maybe something to think
about. My guess is that this may happen, but the time constant of such a floppy, relatively central shunt is too short to be how to say. So it's a time constant is too short that these bumps should go into medium frequency range, which we sometimes encounter, that instead of this hyperbolic and the linear shape of the reactance, there can be bumps, but I can't imagine that this would happen.
Yeah,
5 Hertz or below.
Yeah, I don't know how to behave. I see your point, though.
Yeah.
Mhm.
Gentlemen, for the sake of time, I'm going to invoke closure because I want Frederick to have adequate time. I'm going to invite one last comment from Frans de Jonge, who also has great or a vast experience in using the iOS system, and gave us his insights into pulmonary function testing in the COVID era last session. Frans, are you able to unmute your microphone, show us your face via the video, and comment on this talk?
Thank you. I hope you can hear me now.
I can hear you, and
and you can see me perhaps now. Indeed, we worked also with the iOS for a long time, bronchial provocation tests for children in cold conditions, and we did see that the iOS had a different resistance for the low frequencies. Compared to other systems. At that moment, we compared it with many systems, and most of the work was done by the predecessor of me, Ellie Oostveen, who you might know is having the key paper in the ARJ about oscillometry. And already Ellie pointed out that she thought that how the iOS measured the results for the low frequencies might be suboptimal if she compared it with all the other systems. At the moment, we had a discussion, I know at that ERS Congress, also with Hans-Jürgen Smit, and we didn't come to a satisfactory solution. We now see that we have this, well, I would not say strange results, but this deviating results from normal. I'm willing to see if I can come to an explanation myself, but I think the talk just given was already, I think, spot on what might be the problem.
Well, that's great. I'm happy to see us bringing this issue out in the open to resolve it rather than continuously sweeping it under the carpet. And this is really what science and symposiums are all about. We can all leave our biases at the door and talk objectively like adults. This has been a really great discussion. And thanks, Jewel.
Really appreciate it.
So with that, I'm going to move on to Frederick from Heidelberg, who I see patiently waiting his turn. I promise I will not cut you off. I won't even advise you of the 10-minute mark. You have as much time as you want, given that we've left you only, I think, somewhat less than 15 minutes until 9 o'clock. So the floor is yours as long as you want it, but I think you have the anchor position in the series and really talking about a topic which has preoccupied much of our thoughts and energies over the past 6 months. So please take over the screen, Frederick, and then I look forward to a discussion after that. So please take it away.
So thanks, Ron, for the kind invitation and the offer. Also, I will, of course, try to stick to my 10 or 12 minutes and don't want to extend it. And I'm really glad that I may present our rather preliminary data, of course, on oscillometry and a possible link to small airway disease in COVID patients. So I think most knowledge we have in COVID-19, we all share is largely anecdotal. So we don't have much evidence, of course, given the recent pandemic. And I just want to discuss and give some background what we thought about the small airways in COVID and what we've been doing so far, being linked to previous data others have had. So these are my potential conflicts of interest. And I want to go to some, or I want to do some time travel with you and to back in 1976. So in 1976, we had the space shuttle launch, the first. We had Jimmy Carter being elected for president. We had the Concorde flying from Europe to New York. And we had the Montreal Olympics, which we could all have visited the Olympic Stadium if we could have been to Montreal, which we will hopefully be next year. And of course, we also had spirometry. What that has to do 76 with my talk, I will come back to that later on. But first, let's put that a little bit in context and set the field for oscillometry. So we all know, I don't have to tell it in this context and in this audience, that small airway function is, of course, a rather complex thing, and we have different techniques. We all know spirometry, of course, and transfer factor and body plethysmography. We also have imaging techniques, and we have what we all like so much, oscillometry, which will, of course, be a big part of small airway function in my talk. And we already discussed earlier the multiple breath washout, which we are also a big fan of, or other techniques such as capnal volumetry or the pheno measurements and stuff. So in short, small airway function is a really complex thing. So it's been shown in COPD patients that small airway function is closely linked to symptoms. So what you can see here is that patients, even in the early stages, and especially in the symptomatic B and B stages, they have affection of small airways considerably often as compared to the patients in later stages. And it's like 90% in GOLD D where patients have symptoms, but what we refer to as early disease today. And as I said, it's linked to symptoms, which is important in my point of view. And most notably, it's cough, phlegm, and breathlessness. So the classical COPD symptoms we are talking about at this point here. And what's also important, you can measure that with oscillometry in COPD patients. So what's the link to COVID-19 and other viruses? We have some longitudinal data from the first version of SARS that occurred in 2003, and what we found, what others found, what we share nowadays is that you have a considerable number of lung injury in these patients, and this lung injury it stays over time. So we can follow up those patients for like 18 years now, and there's a considerable number of patients who still have a lung injury of what sort ever, but there's some impairment in lung function. Without getting into details at this time, because we have some preliminary data on the COVID-19, and this is a post-infection cohort we are gathering here at Heidelberg, and those are some 250 patients we collected here. And what you can see quite impressively, I think, is that those patients are highly symptomatic at time of infection. And the most frequent symptom, of course, is olfactory loss and cough, fever, dyspnea, everything. We are quite firm with that for now. But this is the important point of our investigation, I think. 60 days after infection, half of the patients still report symptoms, and dyspnea is the most frequently reported symptom in those patients after infection. And what I found interesting, and this has come up during the review, the paper is currently under, the revision is currently under review, and what's been discussed is a good point at this time. We divided the patients between the symptomatic and asymptomatic group. And what we found is that patients with symptoms, they have a significantly lower, I don't like the term statistically significant much, but what you can really see here is that it's significantly lower FEV1, significantly lower vital capacity, and also transfer factor. And that fits perfectly to that what we know from the SARS-1 pandemic. Also, those patients had reduced vital capacity and most notably transfer factor. But what's undeniable at this point is, of course, that those values are largely normal. So they are lower, of course, than in the asymptomatic patients, but they are still mostly normal. So you can decide if you have a distinct patient, is the lung function impaired or not, especially if you do not have any any values for comparison, which we did not have in these patients because they were really, really healthy. So this is the important point of this investigation. Those were middle age, like 40 to 50, median age patients without any relevant comorbidities. And these patients still had symptoms after infection, like 2 months later. So this may be the place or a potential link where oscillometry can help. And we did some, I want to present some preliminary data on that with all the caution you have to put into interpretation of this early findings. So it's not a new point, of course, because there's a really impressive, and this is where we can make the link to 1976, because this is the year where I think a really important work was published by Hall and co-workers. They had longitudinal data using with forced oscillation technique at that time, of course, and they had patients with influenza, seasonal influenza A patients. And what they could demonstrate, which is really impressive in my point of view, that they couldn't detect any central airway obstruction at this point. And so they also could not detect any changes in, or relevant changes in that, neither in what is considered in small airway function from spirometry. It's the MMEF in this investigation, but you could also do that with the MEF25 and stuff. So no change in central airway or spirometry parameters, but in the small airway, frequency dependence of resistance, inertia, whatever you take, it's a 40% drop. And interestingly, we just discussed that the R3, what we're doing with impulse oscillometry or also AOS at the R5 level, but the story is always the same. You can see a considerable improvement over time in patients with seasonal influenza as compared to the non-detectable changes which you can see in spirometry. So let's come finally to our data we have at the moment, and with all the caution, I already said that because it's on like 15 or 14 patients limited at this time. But what you can already see here is that patients who remain symptomatic after 60 days have considerably higher D520, so the relative parameter, as compared to the patients who fully recovered and do not have any symptoms. And likewise, you can see some difference in AX, of course, and not so much in the resonance frequency. And of course, here the scaling is not ideal, but you can also see some differences in R520 as an absolute value. So taken together, there seem to be considerable differences in small airway function between those two groups in patients who recovered and who remain symptomatic. And what it's interesting at that point, you see some change in FEV1, but it's not as large as you can see in D520. And on the other side, you can also see reduction in transfer factor, which we had also seen in our huge collective. So at this point, maybe let me summarize that small airway disease may provide the missing link between symptomatic and asymptomatic COVID-19 reconvalescence. And oscillometry seems to be a feasible tool for a non-invasive point of care assessment in these patients, which we did with the tremorflow with airwave oscillometry. And of course, longitudinal data and additional measurements in acutely infected patients are needed at that point. And to sum up, to get the link to 1996, many things have changed in 2020, so we don't have any Olympics here. We don't have the Concorde anymore. We have professional golfers, Rory, we have professional golfers for presidents. We have some really spacey things, and technology has improved concerning the space shuttle. We have like SpaceX. And of course, also spirometry has evolved at some point. We have oscillometry now. And to sum up, I'm really happy that you had me here, and I'm open for discussion and looking forward to your comments. Thanks a lot.
Frederick, thank you very, very much. We'll hand the floor over to Sam Bayat from Grenoble to lead discussion. Sam, are you there?
Hello. Yes, I hope you can hear me.
I can and able to. Welcome.
Yeah, so thanks very much, Frederick, for these fascinating data. Really interesting talk. So I gather this was the final talk of the last seminar. So congratulations for that. And thanks to Ron again for organizing these seminars. I've been learning a lot. So one comment about these, let's say, preliminary data that are really interesting. And that is that, well, a few weeks ago, there was a presentation by David Kachka where he tried to model the peripheral airway constriction. And this brought up the questions about how well the frequency dependence of the oscillatory parameters, reactance and resistance, actually identify small airway disease. And this also brought up the question of the mechanisms behind this frequency dependence. And then it was discussed that these are several, and one of them being obviously the increases in the small airway resistance, but also the heterogeneity, which is being explained as differences in the time constants in the parallel airspaces, but also there's role of the compliance of the conducting airways, and all of those were really nicely discussed by Jason, by Zoli, and others. So keeping in mind that, you know, several of these mechanisms can be going on at the same time. Now regarding COVID, I think we're still learning a lot about what the actual consequences of COVID can be to the lung. And these go anywhere from, you know, ground glass, especially in patients recovering from COVID, that they go from ground glass to bronchiolitis to outright fibrosis, perhaps remaining. And there are also data about the SARS-1 epidemic that went on in 2003. So this brings to the question of, is there an evidence gap for the link between small airway disease and the changes in the clinical oscillometric parameters? As you pointed out in the study by Hall, the R5 parameters didn't significantly change, although there was a trend towards a decrease with time in the influenza patients. And there clearly is evidence from imaging data, imaging studies, both experimental and clinical, that there is a link between small airway changes and or heterogeneity and the frequency dependence of both resistance and reactance. But then my question was, should we, in this kind of study, particularly in COVID patients or in other types of diseases, should we associate other means of assessing small airway function in these patients, along with oscillatory measurements, such as multiple breath washout and or imaging? For example, in these COVID-19 patients, I've been wondering if they had any imaging. So Frederick, with that, I give.
Thanks. That's a really important point. And I think it's hard at this time to reduce small airway function to one technique or even one parameter. So I think it's a good it would be a good point to combine multiple techniques, just as we also I illustrated on our on the ERJ figure. There are different phenotypes or domains, I say, of small airway dysfunction, and of course. Resistance is one point, but also ventilation heterogeneity, which you may assess using imaging techniques. MRI, of course, is an important technique, but it's not for clinical use, or the washout testing, which we do a lot. Also imaging, quantitative imaging in an expiratory. And I think in the end, you have, when you want to learn about the diseases, we have to put the picture together. So I'm not saying at this point, frankly, that I may reduce it to one parameter or to oscillometry solely, but I think there may be some composite index or point taking all those parameters together and get a picture. So I'm also not sometimes you may think that I'm against spirometry. I'm not, because spirometry is of course an important part, but I think you have to use other complementary techniques such as oscillometry, washout testing, also imaging techniques together. And you mentioned CT scanning, which I also think is important. We do have some imaging data on these patients, but imaging is always a bit complicated in a clinical setting, and you can see changes in those patients and impairment when you work it up. I think the most crucial part in CT scanning at the moment is the resolution. So we have some 0.6 millimeter resolution slice thickness, which is quite good, but of course it's not a nano CT scan where you have really the resolution in the small airway considerably below that threshold. So I think yes, you have. I think the important point will be to put the picture together using also different techniques. Regarding the point what we're actually measuring, I know that I couldn't attend the talk where it's been discussed, sadly, but there's been a nice paper in the Blue Journal by Foy et al. Last year where they did some modeling based on CT scanning, and proving with clinical data is always something, I guess, from a mathematical standpoint and from a scientific standpoint. But I think it's a really good paper where they could demonstrate also therapeutic effects, and that one part of the puzzle that we're really measuring small airway function or parts of small airway function with oscillometry. So taken together, it's a very important point, and I think we have to address those different domains. It's not just resistance in small airways, the infection in COVID-19, definitely not.
Thanks, Frederick. And I think there's also a question about what is the definition of D520 in percentage?
Yeah, thanks. I just read it. I didn't make that clear. Sorry for that. I'm differentiating between the R520, which is rather the absolute value in pressure units, and what I tend to use more is the relative. So if you divide it by R20 again, so some relative frequency dependence of resistance, which takes into account that a 0.03 change, of course, is different in a patient who has a base value of 0.2 as compared to a healthy person with 0.02 or stuff. So just to adjust the magnitude effect. So in FEV1, it's the same story. If you have a 30 milliliters change and you have a baseline value of 800 milliliters, then 30 milliliters is much more than if you have 2 liters FEV1. And this is why I've been presenting both, because I'm of course aware that the absolute value is more well known.
Frederick, is there anybody apart from your group that is using that metric or has published any experience with it? It sounds reasonable, but when you throw a new parameter, people are always going to challenge you. So I also congratulate you for having the fortitude and the guts to do that in this venue.
Yeah, thanks. So I think we're not the only persons, of course, who had the idea, and with all the caution, I want to emphasize that from our data, I think it's just a very interesting view on the pandemic and on COVID-19. And I'm not aware that anybody has published the data yet or has considerable comparable collectives, but I think there will. I see our data as some proof of concept or basis for all of us to have some new ideas, or maybe one direction that may be worth following, or that may be interesting for us as scientists to look at.
Any plans with the second wave upon us of looking at things going forward as people become infected and get sicker, as opposed to what you're doing now is watching them recover?
Yeah. So this is the important point, and we missed that during the first wave, so to speak, although we were really fast. So you can do drug studies in like 4 weeks or so, which takes in Germany like 2 years usually. And we had like 4 weeks set up, but we missed the first wave, so to speak. Like I think many of us had the problem. Luckily, we made it through the first wave, but if a second wave would appear here in Germany, we have rather low numbers at the moment. But for a second wave, we would be prepared, and I think it will be like they did in influenza, the hard work. I think this will be extremely interesting data. So if you can find predictors in the small airways, for example, in people who worsen, we don't have any clue in that. We see patients who get sicker after 1 week of infection. Some just recover. Some end up on ECMO support and on intensive care after 1 week. And maybe there may be some predictors, but we don't have these longitudinal data, but we urgently need it, of course. And maybe we can altogether deliver it. It will be an interesting data set, I guess.
Indeed, it's a huge unmet need. Sam, do you have other?
I had a question, Ron. Just hang on a sec. In your data set, as you correctly point out, the changes you're measuring are pretty subtle, and yet the patients are reporting persistent dyspnea, is what I gather. Do you have any thoughts about why there's the disconnect or what might be causing the dyspnea? Because it doesn't look to be abnormal lung function per se.
No, I really think I'm completely with you. It's surely not the conventional lung function testing. There has been some reports on muscle weakness because many of those patients also report this fatigue. I just had 2 patients in our outpatient department who just had fatigue, who did sports before and who cannot walk like 2 stairs or stuff. And I think it may be muscle weakness, may be one point of that, but I don't know. It's not fully understood, and I don't know what's the problem. The changes are subtle, and this is where oscillometry may come into play, or other techniques, of course, of smaller function. And this we may detect those changes a little bit earlier, but I'm not saying that this is the holy grail and that you can explain all of the symptoms those patients reproducibly have. What we do a lot of in these patients is exercise testing, which is important because many of those patients do not have any symptoms at rest, but under exercise. And when we're talking about dynamic hyperinflation and stuff, I think exercise testing, this is an important parameter. But I would not dare to tell anybody that I fully understood it. I don't have a clue, actually. It's just guessing. We all have just anecdotal reports about what may happen. It's just what I'm guessing and what I'm transferring from other. That may be also important because the data is not as bad as the collective is small. But we can transfer from other diseases. In COPD, I showed you the data. We also have some longitudinal data just been published from Atlantis, the cohort looking at small airway function, where it could be demonstrated that small airway function is predictive for exacerbation risk, just recently on ERS. And I'm just try to put the picture together and to get clues from how is it working in other diseases on COVID.
Thank you.
Thanks.
Well, that must draw things to a close. Sam, do you have a parting comment before I end the meeting? You're muted, Sam. Sam, can you unmute yourself?
Sorry, I always forget that. No, a very short comment is that on the other side of the spectrum, there are also COVID-19 patients who don't feel much dyspnea while their blood gases are highly deranged. And the reasons for that also are unclear. It could be also, neuro consequences of COVID infection, but we're still learning a lot. And that's it.
Okay. Well, if there are no other comments out there, and I don't see anybody posting anything from the chat, except Leonard. Okay, Leonard, why don't you go ahead and ask your question, and then I'll after that.
I'm not sure I'm buying the fatigue idea, because if that was the case, wouldn't they have more problems performing spirometry than oscillometry, because that's totally effort independent?
Yeah, I think it's a good point, and this is what we guess, and others also did guess from the reduction in vital capacity and other parameters. We do not have PI measurements, PI max measurements, for example, sadly, but it would be worth looking at that. And I completely agree with you. So the effort dependent parameters may be more pronounced, of course, as spirometry.
Yeah,
Well,
it should be. Yeah.
I'm no longer worried about running over time, so I think there's two other questions that I'm not going to cut off. Chung Wei, you had a question, and then Stuart, you had a question.
Yeah, so I wonder, in your population, in those 250 patients, how many of those were post-ICU patients? Because I think we do know that, you know, with critical illness, this fatigue and dyspnea can last for years.
It were really little. It was 3 patients that were in ICU. So most of those patients were in home quarantine, and the small amount don't nail me on the number, but it was like 10%, I guess, 10-12% who had to be admitted to the hospital normal ward, and it were 2 or 3 patients admitted to the ICU. So it's a really small amount of patients post ICU, mostly healthy people with they didn't receive any medication either. So more than 90% didn't receive any medication, and most of them who were treated symptomatically.
Very interesting. Thank you.
Thanks.
Can I ask another question? So I see Stuart, he had a question about cardiac function, and that's kind of interesting too. Did you by any chance measure pulse oximetry or oxygenation in any shape or form? Because that could give an indication if somebody would be having circulatory issues without the lung issues, and vice versa, of course.
Yeah. Good point. It's referring to what Sam said before, the circulation problems. Under exercise, we see patients who have oxygenation failure, or who hyperventilate and stuff, or they even decrease with the oxygen under exercise. And I think this may refer to some circulatory problem, which has been described with the pulmonary embolism theories, which were found in autopsy studies and so on. I think it's not fully understood at the moment. And then you also have some ventilation perfusion mismatch, of course. And for me at the time, it's not understood, but it's an important point. And I think we have different phenotypes of the disease. And this is one important one, which we see in younger patients often, who have like 70 millimeter mercury in blood gas analysis, and they drop for healthy people, before healthy people. So yeah, it's a very important point. I'm always asked by our residents and stuff, but I can't tell them what to do actually.
Stuart, do you want to elaborate on your question?
Yeah, I mean, just to comment that there are obviously, you know, MRI and other evidence of cardiac dysfunction. You mentioned also the pulmonary vasculature, and obviously it's a very complex and multifaceted problem, and I think more extensive, you know, prospective and systematic evaluation would be useful. Unfortunately, we may get to that in terms of having a second wave, but it just raises lots of questions. Certainly in the ARDS patient population, there's a lot of persistent morbidity and mortality in the absence of lung dysfunction over time. So, you know, I think it's very complicated, and hopefully we'll get a little bit more information in this particular setting.
Okay, great. Frederick, thank you very much. Sam, thank you. Thank you to all of the speakers today and at the previous three seminars. I think we'll wrap things up at this point. Stuart and I are looking forward to welcoming you all in person to Montreal next summer, when we hope that we'll be able to have the seminar as it usually is in person, because what's missing this year, of course, is the oscillometry supper, which is as much fun, if not more, than the seminar itself. So with that, I'll close down. A last thank you to our industry sponsors, who in non-virtual times makes it possible, and in these virtual times have stepped up to fund the website. Everybody stay well, and we'll see each other in email chats, etc., over the coming year, and in person whenever we're allowed.